Hello guys, how are you all? Welcome back to MedSteps General Surgery Series by Dr. Anand. So today we are going to discuss very important topic and most commonly we can see in accidental emergency department or normally in OPD. So the condition name is anal fissures. So by the end of this section, you should be able to understand about define anal fissures and pathophysiology and the causes and risk factors and how to recognize, how to identify and diagnosis and grading severity and how to do proper management and indications for surgery. So and for you, if you are preparing for any high yield examinations, this is very high yield topic. So if you're preparing for any exams, so this topic is very important. Okay, so without time waste, let's start. So first of all, definition of anal fissures. Anal fissures is a longitudinal Anal fissures is a longitudinal tear, means it will, because of tear it will cause ulcer. So in the anadome distal to the dentate line, causing severe pain during defecation. So the most common, it's benign anal condition. So usually we can see single and extremely painful, and it's common in young adults. So if you're seeing surgical anatomy, mostly you can see this type of anal fissures 90% is in midline. You can see here, this is midline. You can see why, because the 90% of posterior midline you can see, and 10% of anterior midline, and lateral fissures you can see, that is because of suspecting some underlying diseases. Okay, why posterior? Because this posterior area you can see here, for example, this is the posterior area here. Why mostly you can see in posterior area? Because in that um, in posterior midline you can see poor blood supply. Okay, and whenever the sphincter is working, the greater sphincteric pressure mostly you can see in anal fissure, and because of poor blood supply it can lead to ischemia. Okay, so and if it's become the patient getting any the tear, but problem is in fissure the patient because of poor blood supply, because of ischemia, it's not going to heal fast. Okay, yeah, you can see this type of fissure. Okay, so this is real picture. Okay, so this is the main thing. You can see this type of anal fissure in anal area. So pathophysiology, why this anal fissures the patient will get? Because of constipation and heart stool. Whenever patient is not taking proper fiber food and low water consumption, dehydration, then the patient will get hard stool like constipation. Then after, because of constipation while passing stool, the patient will get trauma in anal canal. Then after, the patient will get longitudinal tear. Then patient will get severe pain whenever they're passing. Then after, here what happened, the internal anal sphincter will get spasm and the blood supply will reduce, and we can see poor healing and persistent tear, and at last the patient will get chronic anal fissure. Okay, so how we can differentiate with acute versus chronic fissure? If it's acute, means we can see less than 6 weeks, and the tear will be like fresh tear, and we can see minimal fibrosis, and no skin tag, and no exposed muscle. So that is acute anal fissure. Next, in chronic anal fissure, we can see more than 6 weeks, and you can see deep ulcer, fibrosis present, and sentinel pile, internal sphincter fibers will be visible. Okay, we can see here, this is dentate line. Because of this anal fissure, we can see hypertrophied anal papilla and sentinel skin tag, that is in severe cases, chronic cases, and you can see fissure with heaped scared edges. Okay, next we have some causes. The causes divided into two different causes. One is primary and secondary. In primary causes, we can see constipation, hard stool, straining, and low fiber diet. In secondary causes, we can see Crohn's disease, tuberculosis, HIV, and syphilis, and anal cancer and leukemia. So these are the main causes you can see. Next one, risk factors. We have some risk factors of anal fissure, that is chronic constipation, repeated diarrhea and pregnancy, childbirth, anal intercourse, and obesity, and low water intake and sedentary lifestyle. These are the main risk factors can cause anal anal fissures. Okay, so we have some clinical features like whenever patient have this anal fissures, the patient will get severe pain during defecation, and the patient will tell like I'm getting pain like knife stabbing pain. That type of pain they will describe. Okay, the pain will lasting minutes to hours, and the bright red bleeding we can see, and constipation, and fear of passing stool, and patient will get itching because of the tear irritation. Next, we can see some signs like visible tear and sentinel pile. That means if patient um, anal canal, here the patient have anal fissure. The patient will get one sentinel tag going down like tag protrusion. So that thing we call sentinel tag. Next, we can see hypertrophied anal papilla and sphincter spasm. We can see in signs. Okay. Typically, whenever I saw one patient came to the OPD when I'm doing general surgery department, that time the doctor he told doctor I'm getting severe cutting pain while passing stool. It lasts for 1 to 2 hours, and I notice whenever he's wiping with toilet paper tissue, that time is getting fresh blood on the toilet paper. So this is classic history of anal fissure. Okay. Next, we can see investigation. In investigation, we have to do labs. In labs, CBC. In CBC, hemoglobin, we can say the hemoglobin will reduce because of too much bleeding, and WBC because of inflammation, leukocytosis we can see. Next one, CRP. CRP if less than 5 milligram per deciliter, then it's normal. If you go more than 5 milligram, 5 mg per liter, then we have to think about patient have infection. Okay, we can do some additional test like colonoscopy in selected cases if you're suspecting any other pathological conditions. Next one, biopsy for atypical fissures. We have to do biopsy is the best option. Next one, HIV test if indicated. Okay, next TB, tuberculosis evaluation we have to do. Then after MRI, pelvis, it will be like rare cases. Next, diagnosis. In diagnosis, based on diagnosis is usually mainly clinically based on history, inspection, and gentle examination. And we have to avoid painful DRE, digital rectal examination, in acute fissures because you are going to irritate more. That's why. So next we can see here that is severity grading. We have total 3 different severity grading. One is mild, moderate, severe. In mild, you can see small acute fissures. In moderate, you can see persistent pain and bleeding. In severe, you can see chronic fissure, sentinel pile, and sphincter spasm. Okay. So next we can see some. Next we can how to manage the patient with anal fissures. First of all, lifestyle modification. Patient have to take high fiber diet for reducing constipation issues, and patient have to drink at least 2 to 3 liters water per day. End of the day, you have to complete 3 liters of water. Patient have to do some regular exercise, and patient have to avoid sedentary life like sitting long time because of pressure. The sphincter will become little loose. Okay, then it's very prone to get fissures. Then after stool softness we have to use. Then after sidge bath, what it means? Sidge bath means it's like 15 to 20 minutes. 50 to 20 minutes in warm water. The patient have to sit at least 3 to 4 times per day. The main benefits of the sidge bath is to relieve pain and to improve blood flow and to reduce a sphincter spasm and to promote healing. And the patient, we have to counsel that patient to avoid straining too much while passing stool along with the delaying defecation. Okay. Next, pharmacological management. For pain, we can use paracetamol or ibuprofen. Paracetamol like analgesic 500 to 1000 milligram we can give orally. every 6 to 8 hours when patient getting pain. Next one, ibuprofen, like NSAIDs, 400 milligram orally, we can give 3 times per day. 3 to 5 days. Pain, we have to avoid if patient have peptic ulcer and renal diseases, we have to avoid ibuprofen. Next one, you can see some laxatives like lactulose and polyethylene. Lactulose will be like osmotic laxative, 15 to 30 ml orally. We have to give 1 time per day or 2 times per day, uh, like 2 to 6 weeks for reducing constipation and to adjust to soft stools. And polyethylene glycol. Polyethylene glycol means it's like osmotic laxative, 17 grams. Orally, we have to give only 1 time per day. 2 to 6 weeks we can give for constipation. It's the main medication laxative. It's like effective for stool softener. Next we can give that is docusate. Docusate means it's like stool softener. 100 milligram we can give. Orally, we have to give the main frequency will be like 2 times per day, 2 to 4 weeks. We have to give like for mild constipation, and it will help to prevent hard stools. Next, GTN, glyceryl trinitrate, 0.2 to 0.4 percentage nitrates. We can give the dosage will be like thin layer, and the route will be like topical 2 times per day, and the duration will be like 6 to 8 weeks, and the indications will be like chronic fissure. And if patient have headache is the main common thing for using glyceryl trinitrate. Next, we can give some calcium channel blockers like deltaagin 2%, like thin layer. Topically, we can give to apply on anal fissure, like 6 to 8 weeks. The patient have to use for chronic fissures. It's a better tolerated than GTN. Okay, next one, nifedipine calcium channel blocker like 0.2 to 0.5 percentage we have to give calcium channel blocker. It's a thin layer, topical 2 times per day, 6 to 8 weeks, chronic if patient have chronic fissure, and alternative topical agent we can use. Now we have how we can manage that patient. We have first line management, that is Sidge bath, 15 to 20 minutes warm Sidge bath we have to take, and fiber supplements the patient have to take along with the stool softeners. It may be lactulose or polyethylene glycol or docusate. These are the stool softeners and topical GTN, a topical calcium channel blocker deltaagin. In second line management, we can use botulinum toxin injection and repeated medical therapy and surgical. We have to do surgical referral. Okay, so we have in surgical management we have one surgery we called lateral internal sphincterectomy. Lateral internal sphincterectomy, why the patient have to do this surgery? Because the main mechanism to reduce sphincter spasm, okay, and improves blood flow, and it will allow healing, and the healing rate will increase greater than 90 to 95 percentage. Okay, so here you can see some other procedures also we can do for anal fissures, like fissurectomy, along with that advancement flap and botulinum toxin injections, which are reserved for selected patients. Severity based management. In mild cases, fiber food and or supplements or fluids and Sidge bath. In moderate case, we have to add topical like GTN and deltaHM and or laxatives. Okay. Next one, severe. In severe cases or chronic cases, we can go with botulinum toxin, or we can go with that lateral internal sphincterotomy. We can go. Okay. So whenever we are using any drugs, every medicine have some side effects or contraindications. We have to know that thing before prescribing any medication. Next, we have some complications like untreated fissures may lead to chronic fissure and sentinel pile, anal stenosis, persistent pain, recurrent bleeding, and fecal impacts. So these are the complications of anal fissure. Next, for follow-up, we have to review after 6 to 8 weeks, and we have to assess like a pain relief and healing, stool consistency, and compliance and recurrence. So if patient have persistent symptoms, that we can use surgical evaluation. So in exam point of view, most commonly they can ask some questions like posterior midline is the most common for anal fissures, and if any the main anal fissures of pain during defecation, we can say that is the main hallmark. Next, we can see bright red blood and sentinel pile. We can see in chronic fissures, and if patient have internal sphincter spasm, we can see this causes poor healing. Next, topical um, GTN and delta chronic calcium channel blocker, first line for chronic fissures. Next, you can see lateral internal sphincterotomy, like gold standard surgery. And lateral fissure is, we have to, whenever patient getting lateral fissure, we have to suspect Crohn's disease, tuberculosis, HIV, and malignancy. Okay. So these are the things. Whenever patient coming to accident emergency department or OPD, if you're suspecting anal fissures, if less than 6 weeks, that is acute. If it's more than 6 weeks, that is chronic. So we have to tell the patient to take fiber food fluids, switch bath, then after stool softener. If it's improving, okay, we have to check after 2 weeks. If it's continue, then we have to go with if it's improving means you can go with normal that management. If it's not improving, then you have to go with topical GTN and delta HM. Then after, if it's improving, okay, you have to continue with the GTN and delta HM, calcium channel blocker, topical. If it's not improving, then you have to go with botulinum toxin, and you have to go with persistent chronic fissures. Then after, lateral internal sphincterotomy. Okay. So these are the things. Mostly I covered everything about anal fissures. If you have any doubt, you can ask me in comment section. So we will discuss our next topic like around like anal fistula. We are going to discuss in upcoming videos. Okay. If you didn't watch our general surgery topics, everything, we have some playlist, you can go and watch. Okay. You can follow me through Telegram MedSteps channel, and in Instagram Dr. Anand Jana. Okay. So we will meet in our next video. Till the time, take